We are live and now we need to share it to a group. So I need 1 minute to share it. Ma'am, let's start. আসসালামু আলাইকুম এভরিওয়ান, আমি রাফিউজ্জামান রাফি। মূলত আজকে আমাদের প্রোগ্রাম শুরু হচ্ছে। তো আমাদের প্রোগ্রামের আজকের গেস্ট হিসেবে আছেন ডক্টর রাজিব আল হাসান ম্যাম, ডক্টর সঞ্জীব স্যার এবং ডক্টর উমর স্যার। And the Rajiv ma'am will host the moderate the program. And before start the program, I will start with a question from an individual. Ma'am, a question from an individual. After answering the question, we'll start the main session, and ma'am will moderate everything. My question is for everyone. The question is: one of us went through a transplant since 13 years back in Singapore, and recently, most probably, he has a chronic antibody-mediated rejection, and now we want to go for a second transplant, and he has cross-matched with 4, 5, or 6 donor, and his PRA report is almost normal, and his flow and CDC cross-match is also negative. But he think ACLA is most important, and he is very much afraid of going for the transplant. Is it really necessary for being ACLA match for second transplant, and how much important it is? And without ACLA matching, if the CDC and progress match is good, his PRA report is good, is it safe to go with a transplant, second transplant? And this is my question.
Sanjeev, you'll take this question. You're muted, Sanjeev.
Sir, will you please unmute your microphone?
Yeah, hi. Thanks for the question. I think some of this will be covered in more detail during our session, which Rajiva will moderate. But for any transplant, first or second, to work successfully, the better the HLA match is, the more successful the transplant is. If you have an identical twin full HLA match, your rate of success of the transplant is much higher. But if your HLA is a complete mismatch, then your risk of a rejection is higher. So for any transplant, you will still do an HLA match. So it's not just based on the PRA. If you have to do a flow, you have to have a donor. And for that donor, you will automatically do an HLA match. Only with the HLA match, you will know what your level of sensitization is to that particular donor, especially since he's already had a previous transplant. So an HLA match is required. You can't go ahead for a second transplant without an HLA match with the donor.
No, sir. I'm not indicating that. I'm not just indicating that he has not done ACLA. He has done with VCLA, but not totally matched, or 20% or 90%.
Okay, the HLA is a mismatch. That's what you're saying?
Yes, sir.
Okay, so it is the same story. We'll have to do testing to see what the CDC cross matches, what the flow cross matches, and what the level of sensitization based on a virtual cross matches. And based on what we are seeing in those tests, we can give him a certain idea of what his risk of rejection is. So just because it is not matched, there is no need for him to be thinking that he cannot do the transplant. For example, if you're doing a deceased donor transplant, if you're doing a cadaver transplant, somebody who's dead and donating, that is an unrelated transplant. That is likely to be a zero match, HLA. But you will still do that transplant, even though it is zero match. So it's not just the degree of HLA match, although that is important. We also have to see what his level of sensitization to that specific donor is, if he has a donor lined up.
Okay, sir. And that was my question. Now I will request Rajiva ma'am to moderate the whole session, and now we'll leave from the scheme. Ma'am, will you please continue?
Yeah, thank you, Rafiq. Thank
Thank
you
you.
for the kind introduction. And welcome to this panel on second transplants. So, I think getting a first transplant itself is a life changing event for so many people. But unfortunately, a graft or an allograft, that is a kidney allograft, is not forever, because finally there are so many processes that can damage the kidney as time goes, and many people may still require a second transplant and even a third transplant for that matter. So, Dr. Omar, what, in your opinion, are the causes of uh, a transplant kidney to fail in the long
There
run?
is so many reason in our country for failing the transplant kidney initially when there is a first time they transplant, because they do not follow the infections rule. As they when they completed their transplant, they openly move around, they go to the market, and most of them also do not adhere with the treatment actually. So there is a more chance of infection there, and also the cost is something that might affect their treatment adherence, and some of them actually lost the follow-up also. So there is the one reason is there is infection, another they do not exactly follow the treatment what they are advised, and some of them lost their follow-up, and also economy issues also there in Bangladesh. So sometimes it's very costly for some person who are not actually well solvent enough in their economic basis. So these are the things that actually happens, and also the education about transplant. So what actually they do after the renal transplant. So there is something that lack in here. The patient education is also most important for proper graft functioning. This is, I think, ma'am.
And the social causes are fairly very important, and pretty much with the theme of of the World Kidney Day, which is equitable access for all and actual proper medical care. So that being said, what are the medical problems, Sanjeev, which can affect any allograft in the long run or the short run? So, and that's one of the questions I think Rafiq put forward to us. So, why does a kidney transplant fail at some point?
Should I answer, Rajiva?
Yeah, yeah, yeah.
Yeah, so I think the most important thing that all our listeners should be knowing and understanding is that a transplant is not a cure for your original kidney disease. It is, in the end of the day, it is a therapy. It is a treatment option that we are giving for failed kidneys. We are putting another kidney from donated by somebody else into your body. So just like any other treatment, a transplant has complications, side effects, and may not work completely. So, from the point of time of the transplant surgery itself, there is surgical complications. From that point itself, you can have reasons for the graft, the transplanted kidney failing. You can have technical complications during surgery. You can have blood clots in the blood vessels, which are stitched together, the kidney's artery to the recipient's artery, or the kidney vein to the recipient's vein. You can have blood clots in that. You can have a stenosis, a narrowing of those blood vessels, which can cause poor flow to the kidney, to the transplanted kidney. Uh, Sometimes, if uh, the donor is many times, because you don't have any other donor, you take what we call a marginal donor, which is like somebody who's very old, or somebody whose kidneys were not the healthiest kidney. They have diabetes, they have hypertension, they have some changes of that disease in their kidney, which has been donated. If any of these things are there, you can have a graft which is not functioning well to begin with and then becomes lost eventually from the surgical point itself. In addition to this, the most common cause of graft loss is a rejection. A rejection is when your body's immunity, that is the recipient's, the patient's immunity, acts against the kidney and damages it and destroys it to a point where the kidney is not working anymore. Now, you can have a rejection which is acute, which means that we have done the transplant, and soon after we have done the transplant, within days or weeks of the transplant, you can get a rejection. That's an acute rejection. And you can have a chronic rejection, which is a slow process of the body rejecting this kidney, which happens over months or years. Both of these can result in a graft loss or a kidney failing completely. Now, in addition to this, the rejections can be divided into something called a cellular rejection or an antibody-mediated rejection. Cellular rejections are slightly more easier to treat. Antibody-mediated rejections happen when the patient is already sensitized, something that we'll discuss, I think, going forward. And that can cause graft loss. There are also any number of infections, which Dr. Omar already spoke about. And you can get infections because either you're taking too much immunosuppression medicines or you are being too exposed to, you're not get to so those infections can be pick up they can be fungal infections which you can pick up from the be viral infections pick up from or from already
I think Dr. Sanjeev's connection is a bit off, but basically those are the causes or medical causes why a kidney may not be there forever. Antibody mediated rejection, cell mediated rejection, infections, these are the common causes. Um, so yeah, so Dr. Omar, hi, you're back, I think. You can hear me?
Ma'am, I can hear you.
Yeah. So, what is the general longevity of a good allograft? Say that we put in a kidney from a well matched donor, everything has gone on well, there are no surgical problems. And then, kind of this guy has this transplant. For how long can this patient actually sustain with this allograft? So, many people ask us, for how long will this transplant last?
Ma'am, actually, there is no definite time duration, but it may work as long as even there is a evidence that it may last more than 20 years also. There is an evidence the patient survive, but it depends on some factors, actually, how his immune system and how his body reacts against the second transplant kidney. So actually, there is a chance he can back to his normal life by the second transplant as like a some same transplant. So there is actually not, I cannot actually mention that it will stay 5 years, 10 years, 20 years, but there is a high chance of it can stay a so long time. Actually, with the if it's balance, it maintains so good in the proper, is if he taking the medication regularly and it's with the clear with the good follow up, then it can stay. I think it can stay long.
So I think the median sort of a time that any allograft lasts is around 8 to 10 years. If everything goes well, it's a well-matched living donor kidney. Then I think to a large extent, up to around 8 to 10 years, you can have a well-functioning allograft. After that, there are so many other reasons that the allograft can start failing, as Dr. Sanjeev has already mentioned. Dr. Sanjeev, there's a lot of trepidation or fear when somebody's allograft has failed. There's a lot of like mental, physical, as well as immunological issues, and actually even financial issues, because this patient has had chronic kidney disease for so long. And then when they come for the second transplant, it's not only the fear in the patient, even the doctor has a lot of fear while doing the second transplant. What is the unique features which are different from somebody undergoing a second transplant versus somebody undergoing a first transplant?
So you can answer that question in two ways. One is to look at it from the patient's point of view, another to look at it from the doctor's point of view or the transplant team's point of view. From the patient's point of view, like you said, there is already, they would have gone through quite a bit of emotional trauma from getting the transplant done, having a successful transplant kidney for some time, and then going through the trauma of having that failed and ending up back on dialysis. There is also a financial cost. Um, uh, Other than that, the question that we have to look at for the patient for a second transplant is whether, because he or she has already undergone a first transplant, whether they are now sensitized, they have a higher immune risk. That is something that we have to see. This will also be very dependent on who the donor is, whether the donor is related or not. If it is a near relative to the first donor, then your risk of a higher degree of sensitization is much more. Also, we have to look at what the original disease is which the patient had, and whether the patient went back to dialysis because of that original disease, and that is why they have lost the graft. If that is the case, sometimes then you can have a graft loss in the second transplant as well. So these are things that we'll have to discuss with the patient. In addition to this, the one thing that you also need to look at is the surgical side of things. So for a surgeon, also there is already a kidney that usually we place a transplant kidney on the right side of the body, in the front of the abdomen. If you're going for a second transplant, uh, sometimes that original kidney, the originally transplanted kidney, is still there, in which case you have to do the second surgery on the left side. If the original transplant kidney is not there, it has been removed for some reason, then it's a slightly more complex surgery, takes slightly longer time. If you have to do a transplant in the second transplant in the same place or in the left side. So there are surgical challenges as well, which the patient will have to consider. Rajiva, everybody's gone.
Yeah, thank you, Sanjeev. We were just kind of unmuting and switching off the videos because of the connection, which is a bit poor. A lot of patients who come for the second transplant are always very kind of suspicious because they ask us, "Ma'am, I've already done a cross match back home. Why do I need so many cross matches? Why do I need antibody testing? Is it really required? What if there is one antibody which is positive against the donor? How does this affect the kidney transplant, especially the second time?"
Okay. So I think to answer this question, we'll have to sort of get you a sort of a broad overview of why we look at these antibodies. So the most important thing for a success of a transplantation is the level of sensitization that the patient has to whoever the donor is. What that means is there are antigens that the recipient, that the donor has, to which the recipient may have antibodies for. Now, the more number of antigens that are there in the donor to which the recipient has antibodies, the greater your risk of rejection. And we know that rejection is the most common cause of graft failure. Now, especially when you're doing a second transplant, you have already been exposed to antigens from your first donor. So because you have already been exposed to antigens from your first donor, you already have those antibodies. And your body does not lose those antibodies. They stay in the body. Even if the antibodies are gone, the body has a memory for those antigens. So if they are exposed to those kind of antigens again, the antibodies will come back. So this much of a broad outline, you have to understand that the body, once it develops antibodies, it can reform those antibodies every time it is exposed to the same antigen. So when you're doing a second transplant, even if you've had a cross match before, you can get a new infection. You can get blood transfusions when you're on dialysis there. If you've been previously, for example, you're a lady who has had a pregnancy and your first donor was, say, your husband, that is one level of sensitization. There are some antigens to your husband that you're already exposed to. If your second transplant is your son, now that is a whole new set of antigens that you're going to be exposed to. So even if you have had a previous cross match, that cross match is not valid forever. You will still have to do a new cross match just to see if you have not developed new antibodies to antigens that you have been exposed to in the gap between your previous cross match and this one. And there are also the level of testing that we do. Previously, you could just get by with doing just a basic cross match. Today, that's not the case. You have to do much more sensitive testing to know what kind of what level of antibodies are there and what that how high the titers are. So that's how we can say how much antibodies there based on the titer levels. So if you have very high titers, then your risk of a rejection is much more higher. If you have antibodies but the titers are low, then even if you have antibodies, we can still consider safely going ahead with a transplant. But if your titers are very high, then sometimes we may even have to reject a particular donor because we know that because the titers are so high, your risk of a rejection and not a long rejection, risk of an immediate rejection of that kidney is very high. So we have to decide based on all these factors whether this particular donor who you're bringing back uh, will suit you for a second transplant.
Thank you, Sanjeev. So, in short, basically, what you mean is it's very important to do a very sensitive level of tests to detect antibodies. Your flow and
Yeah.
CDC should be negative. Your CDC and flow should be negative. And that gives you a better prospect of not having a rejection. And the level of antibodies which are there and what type is there. So there are a lot of types of antibodies, and that also makes a difference in predicting the risk of rejection. Um, the last question, that is the first question which Rafiq had asked us, whether HLA typing is very important. Yes, it's very important. What is more important is that there is an HLA typing and you have any anti-HLA antibodies to that particular HLA typing is what makes a difference to how we are going to deal with this patient. Now, Dr. Sanjeev, as you know, many patients come and when they have antibodies and their CDC and flow is negative, we still may go ahead with transplant. But the problem is, many people think that once you have done things like plasmapheresis or giving rituximab, because many patients do Google, they have talked to other patients, and they come and ask us this: is it true that the antibodies will completely become negative at that point of time, and there is no risk of rejection if you follow something called as a desensitization protocol? Dr. Omar, you want to take that? Please unmute.
Ma'am, there is sound is echoing. I'm not actually here. Hello,
Okay.
ma'am. Can
Can
you
you
hear me?
Sanjeev,
repeat that last question? Can you repeat that last question, Rajiv? I didn't hear it.
yeah, sorry. So, what I wanted to say was you have a CDC flow negative, cross match is negative. There are some antibodies. So, now the patient, as we already know, getting even a CDC and flow cross match negative in a second transplant patient is quite difficult. So at this point, if we do something called as desensitization protocols, that is with plasmapheresis, rituximab, so many patients have already read quite a bit and they come and ask us this. Is it true that the antibodies completely disappear after that and there is no risk of rejection?
Yeah, okay, that's a very good question because it's a very commonly asked question, and the answer to that is no. So even if you can manage to somehow bring down a very high titer level of antibodies with plasma exchange, with IVIG, and with rituximab. Even if you bring it down, like I said before, your body has a memory of these antigen that it has been exposed to. And as soon as it is exposed to a similar antigen again, the body will start producing antibodies. So it is there is no 100% guarantee that if you do all the desensitization protocols, you can do a transplant with zero antibodies and no risk of rejection. That is not possible. So there is always going to be a risk of rejection, which we have to minimize with our desensitization protocols as well as our post-transplant immunosuppressions, which is why a second transplant usually requires a higher level of immunosuppression than the first transplant, because they've already been sensitized once before with the previous transplant, and now you have to do a second transplant, so the risk of sensitization is more.
Thank you, Sanjeev. There are also instances where there is a cross match discrepancy. For example, a flow and a CDC cross match, which is done in remote parts, and then they get it and come. Many a times, when we do a transplant, it turns out to be positive, or the vice versa. In such situations, what are the reasons that can be there in for these changes or discrepancies in the cross match?
See, so what, couple of things here. Let's say you've done a cross match in Bangladesh, and from whatever I am hearing, erythropoietin is very expensive in Bangladesh, so many patients end up getting blood transfusions. So every time you get a blood transfusion, you are getting sensitized again. Okay. Also, sometimes some viral infection, some bacterial infection that you've got. That is another sensitizing event. That means you've had an infection. Because of that infection, you're having new antibodies formed. So you've had a cross match and that was negative. You've had blood transfusions after that, or you've had infections after that. That those two alone can sometimes cause a new formation of new antibodies because you've been exposed to new antigens. That is one. The second is these tests are very, very sensitive and very lab and operator dependent. Which means if you do it in a proper lab, the quality of testing will be very good. So if you do it in a good quality lab, you may end up picking antibody levels which were not there in a lesser quality lab. That also matters. The technique of the lab also matters. Sometimes you get non-HLA antibody. That's another reason why you can get uh, a cross-match positive, especially a virtual cross-match positive.
So, I, Sanjeev, you're back. So, what Sanjeev was trying to
Ma'am,
say was, can you hear me
correct.
now?
Ma'am, can you hear me?
Yeah, yeah, yeah.
Ma'am, actually, I have a questions from audience,
Hmm.
and that is that what precaution they should take before undergoing to their second transplantation, as if they had previous history of acute antibody mediated rejection in the past. So, in case of second transplantation, what precaution they should take to undergo for their second transplantation, and what is the possibilities to survive the graft in that case in compared to their first transplantation?
Thank you, Omar. I think it's a good question. So, when you know that your kidney allograft is failing, you should now decide what you want to do. That is the first thing. Whether you want to just continue on dialysis or you want to undergo another transplant. So, if you are a younger person, so a transplant may be a good option for having a very good quality of life and other benefits of a transplant itself. Now, that being said, one of the best things and most important things is to prevent blood transfusions. Unnecessary blood transfusion leads to more sensitization, and this can actually worsen the sensitization level. So, you're going to get, as Dr. Sanjeev very lucidly explained, you can have more and more antibodies, already you have more. The second is the choice of a good donor. And a good donor doesn't mean that the donor has to only be young and fit. That's not what it is. A good donor is where you are immunologically compatible. Obviously, the donor has to be fit medically, but age does not matter. Many a times we do get questions like, my dad or mother is 60, 65, they can't donate. That's not true. If they are fit, they are not diabetic or hypertensive, or don't have any other chronic issue, they generally can donate. Older donor doesn't matter. What matters is a immunologically compatible donor, right? So blood transfusions you can avoid infections. So one of the things that you can do is get vaccinated appropriately. So before your second transplant, get vaccinated for pneumonia. Ensure that your hepatitis B titers are good. Make sure that you are in a center where there is no outbreak of HCV infection, because many times when we see these patients, they are either hepatitis B positive or hepatitis C positive. Both of this can end up in having problems post second transplant, because already we are going to get more immunosuppression. So these are some of the things I can think of that you can do. And also ensure that you get a good dialysis before you come for your second transplant, because that does matter. And if you have an acute rejection, like for example this month, there is no need to urgently undergo a transplant the very next month. It is always good to give it some time till things settle down, and then sort of work yourself up for a second transplant. So I have a question for Dr. Sanjeev. Sanjeev, you can hear me?
Yeah.
So after this, I think Dr. Omar can take the questions from the audience. One of the things is, what sort of a protocol do you follow in your institute before you do a second transplant?
Yeah. So, like you just said, we have to sort of see the patient in his entirety, his or her entirety. See what kind of sensitization they've had, see how well dialyzed they are, what kind of vaccinations they've done, and see if the patient is fit for a second transplant. That's the first step to see if the patient is fit. So, from not just from a dialysis point of view, from a kidney point of view, but also from a heart point of view, from an infection point of view, whether or not that original kidney has to be removed or not, and uh, then you move to the donor and see what the donor's relationship to the patient is, what the level of sensitization to the patient is, and then only you can consider the patient for a second transplant. So when the patient comes to us, we will do a baseline evaluation of all these things, including a CDC cross match, a flow cross match, and a virtual cross match in our institute. We will also look at, like you said, all the vaccination status, as well as cardiac fitness, pulmonology fitness, and anesthesia fitness for these patients. In addition to all this, if and especially for a second transplant, the chance of a sensitization event is high. So this patient will then have to a plan for a date of surgery. So the surgery has cannot be rushed. It has to be planned so that you can a stabilize the patient, make sure they're well dialyzed, make sure that their blood levels are all appropriate for fitness for transplantation, make sure they're vaccinated pre-transplant so that their risk of infection is lesser, and then plan for a desensitization protocol for usually about a week to 10 days to 2 weeks before the date of surgery, and then only go for a surgery that you can plan for beforehand.
So, with this, hopefully, we have kind of discussed the main points of a second kidney transplant. I request Dr. Omar, who's been very kind to actually come to our institute and spend some time with us, and it's been a start to some amount of sharing of knowledge about what happens in your country and how we deal with things in ours. And always such information helps both of us to manage patients better. So I think we'll take questions from the audience, Dr. Omar, and if needed, you can also translate so that the communication is more effective. Please unmute, Omar.
Ma'am, there is a question from audience regarding the cost issue. And also there is a question regarding the donor issues. The cost issue, they are asking that in case of second transplantation, is it more costly than first transplantation? And regarding the donor issue, if a person underwent to the first transplantation with a family member, and in case of second transplantation, if they're not getting the donor, is the disease donor transplantation will be helpful or beneficial for him for longevity and for transplant kidney to be survived for long time?
So I will take the question on the cost. The cost of the
Okay.
second transplant can be higher because we need to do more, as already mentioned, we need to do more uh, rigorous testing for infection and rejection. So the antibody tests are not cheap, and the infection tests are, we have to do imaging like CT, and this is very, very important. So, and in addition, we also have to see their blood vessels, because these patients have lived with kidney disease for so long, and not the blood vessels not only in the leg, also in the heart. So the coronary blood vessels also have to be seen. So second transplant patients may have more level of cardiac disease when compared to somebody going for the first time for a transplant. So obviously the workup sort of differs from patient to patient, but overall it may be slightly more expensive because of more amount of testing that may be required. Also, since these patients may have a higher risk of rejection post transplant, and that may also have to be treated, they may need more biopsies, more amount of treatment. So this is not, it's not like a one rule fits all. So it is individualized, but definitely it can be a bit more costlier than the first transplant. The donor question Dr. Sanjeev will take.
So yeah, I'll answer the donor question. Look, if you have a live related donor, that is always better in terms of graft outcomes. But that is also dependent on what kind of donor. For example, let me just put it this way. Let's say your donor is your living related donor is a 75-year-old grandmother, and you are a 28-year-old man. Okay, that is not as good a donor as even a deceased donor or or a cousin or somebody else who is much younger. So that's the first question. It matters what kind of donor. If it is someone who's very old or someone who already has diabetes, hypertension, that's not going to be a perfectly fit donor. So donor characteristics matter. But if you're deciding between somebody who has no donor, no living related donors, and who's thinking, should I go for a cadaver transplant? Yes, absolutely. A cadaver transplant has been shown by data that in terms of comparison to a living related donor, the success rates compared to a living related donor is about only 5% lesser to 10% lesser, not more. So if you have a good cadaver transplant program in a center which does high volume cadaver transplants, yes, definitely you can consider a cadaver transplant as a alternative to an absent donor.
Yeah, go on, Dr.
Any
Omar.
other questions, Omar?
Please unmute, Omar.
Another questions from audience side that is related to the dietary issues. As most of the patient were previously CKD stage 5, there were so many restriction over the food. But when they underwent successful renal transplantation, will their previous limitation of food, restriction of food will be continue, or they can eat like as normal person in their post successful transplantation?
Rajiva, I'll answer that. So when your kidney has started functioning again, now you have a normal functioning kidney. The amount of dietary restrictions that you have compared to when you were on dialysis is much lesser. you can drink more water. In fact, if with a functioning kidney, you will be passing a lot more urine. So you'll have to drink a lot more water. You can take some amount of salt. And also what also happens is now that you have a functioning kidney, your appetite will improve. So you will start eating more. The problem with that is the medications that we are giving you, the steroids, the tacrolimus, all of that makes you higher risk for diabetes, and you will end up gaining weight also because of the steroids. So when you are in a situation which is already prone to diabetes and you are eating more because your appetite has improved, if you gain too much weight, then you get diabetes, and then those two problems, increased weight gain and increased blood sugars, can damage your kidney as well as other organs. So it's important that while you understand that yes, you can eat more, your restrictions in diet is not that much. It is also important that you uh, eat within limits, that you do not gain too much weight, and that you exercise also after your first 3 4 months, when you are allowed to go back to work and you return to normal life. Then you also exercise. I initially, at least at home, walking some treadmill or a cycle or something like that at home. And as the graft becomes more and more stable in your body, you can even go out and exercise, go for running. People even go for transplant games. There is like a Instead of Olympic games, there are transplant games where transplant recipients come and participate in sports. So that is possible. So that is also important to do.
Dr.
Okay.
Umar, you just want to tell that in a little bit of
In Bangla. Okay.
Bangla,
Okay.
so in short.
হ্যাঁ, আমি এখন যেটা আমাদের প্রিভিয়াস কোশ্চেনের উত্তরটা দিচ্ছি, যেটা ম্যাডাম বলেছিলেন যে অ্যাকচুয়ালি সেকেন্ড ট্রান্সপ্লান্টের খরচটা প্রথম ট্রান্সপ্লান্টের থেকে বেশি হবে, কারণ সেকেন্ড ট্রান্সপ্লান্টে পরীক্ষা নিরীক্ষা গুলা প্রথম ট্রান্সপ্লান্টের থেকে একটু বেশি লাগে, আর আগে থেকে পেশেন্ট ইমিউনোসাপ্রেসিভ ওষুধের কারণে কিছু কমপ্লিকেশন থাকে, যার কারণে। আর আরেকটা কোশ্চেনের উত্তর হলো সেটা হলো সবসময় রিলেটেড ট্রান্সপ্লান্ট, ফ্যামিলি মেম্বারদের থেকে অর্গান ট্রান্সপ্লান্টেশনটা ভালো। যদি কোনো কারণে সেটা না হয়, সেক্ষেত্রে ডিজিজড অর্গান থেকে, ক্যাডাভার ডোনার থেকেও নেওয়া যাবে, তবে সেটা লংজিভিটি অতটা নাও হইতে পারে, বাট ইটস ডিপেন্ডস অন কিছু সিচুয়েশনের উপরে। আর যদি ট্রান্সপ্লান্ট সাকসেসফুল হয়, সেক্ষেত্রে খাবার দাবারের পূর্বের যে লিমিটেশন ছিল সেগুলা কমবে। তবে যেহেতু ট্রান্সপ্লান্টের পরে লং টাইম স্টেরয়েড জাতীয় ওষুধ খেতে হয়, সেক্ষেত্রে এতে ডায়াবেটিসের ঝুঁকি বাড়ে, এবং এই জন্য ওয়েট গেইন হয় এমন কোনো খাবারটা একটু এড়িয়ে চলা ভালো। তবে নর্মাল লাইফস্টাইল লিড করতে পারবে, কিছু এক্সারসাইজও করা যাবে, এবং নর্মাল ফুড স্টাইল একজন ডায়েটিশিয়ানের সাথে কনসাল্ট করতে পারবে, আর নর্মালি বাকি সব কাজই করতে পারবে। তবে একটু সচেতনতা লাগবে, যেহেতু তারা একটু ইমিউনোসাপ্রেসিভ ড্রাগস এর মধ্যে থাকে, কিছু সতর্কতা অবলম্বন করতে হবে। ওই ইমিউনোসাপ্রেসিভ রিলেটেড ড্রাগ টক্সিসিটি যাতে না হয়, ওই ধরনের কিছু খাবারটা এড়িয়ে চলাটাই ভালো। ওকে ম্যাম, I have translated it in Bangla.
Yeah, thank you, Dr.
3 or 4 questions.
So I think there are a couple of questions in the chat box, and lovely to see you, Rafi. Hope you're doing well. So I think she
Yeah,
has.
hi, Rafi.
Yeah, I she has a couple of questions. That is, how do we decide how much water intake is needed after transplant? Sanjeev?
See, how much water intake is, there is no fixed number. It's not 2 liters, 3 liters. There's no fixed number. It is how much urine are you producing? If you are producing 3 liters of urine, usually post transplant you will be producing a good amount of urine, somewhere between 2 to 4 liters of urine you will produce. Okay. If you're not drinking that much, if you're producing 2 liters of urine and you're not drinking 2 liters, then you'll become dehydrated and low BP will happen. So you have to drink enough water so that your urine, so that you can match your urine output. That's first. Second is, one way of looking at it is to look at your weight and your blood pressure and the color of your urine. For example, in the summer when it's hot, you will sweat more. So you will have to drink more water. If you don't drink enough water, the urine becomes yellow, orange color. If you're drinking enough water, the urine is colorless. So one way to look at how much water you need to drink is to look at the color of your urine. If your urine is colorless, you are drinking enough water. The more yellow the urine becomes, the more water you need to drink. Instead of looking at an exact number, 2 liters, 3 liters, 4 liters, look at the color of your urine. That is one way of looking at it.
So the other question is how much hemoglobin is required in the body. So well, any hemoglobin more than 9 or 10 is ideal, but that does not mean that if the hemoglobin is 8, we don't go ahead with the transplant. If it is absolutely required, we do transfuse blood, and generally, I mean, every good hospital has an excellent blood bank, and where they do store blood, and this and generally what we do is we reserve blood according to the group well in advance before the transplant, so that if a necessity arises, we generally give it. There is one more
Also,
question. Umar.
Okay,
Rajiv,
ma'am,
just hold
there
on
is a
one second.
question from audience, and
Umar, just one second.
Umar, just 1 minute.
Umar, one second. Just to add to that hemoglobin question, if you're planning to get a transplant after getting on dialysis, you should avoid blood transfusions. You should be using erythropoietin and iron only to maintain your hemoglobin as much as possible. It will help decrease your degree of sensitization, and it will decrease your risk of hepatitis B, hepatitis C infections. So that's also something that you should absolutely look at.
Yeah.
Yeah, ma'am. I have a question from audience side for Sanjeev sir, and that is which kind of rejection is common in case of second transplantation, and what precaution to take to avoid this kind of rejection.
So it's again good question. That you can get both types of rejection. There are two types, like I said. There is a cellular rejection, cell-mediated rejection, or an antibody-mediated rejection. You can get both types of rejection at any point during the second transplant. Uh, the risk of an antibody-mediated rejection is higher because you have already been sensitized to a previous donor and maybe also to other blood transfusions in between the first transplant and the second transplant. So if you have an antibody mediated rejection, those are sometimes more difficult to treat and completely correct than a cell mediated rejection. So of the two rejections, the cell mediated rejection is easier to treat than the antibody mediated rejection. The second part of that question was what can you do to avoid the risk? Like I said before, avoid blood transfusions. That's the first. And two, do a proper workup pre-transplant for your immunology. So in a good lab, you'll have to do a CDC cross match, you have to do a flow cross match, and a virtual cross match before your second transplant, so that you know what exactly your risk of sensitization is, what your antibody titers are, and based on that, you can have a proper plan for desensitization.
Okay, I'm translating it to Bangla. That as Sas said, that the antibody there is দুই ধরনের সেল মেডিয়েটেড রিজেকশন এবং অ্যান্টিবডি দুটাই হতে পারে সেকেন্ড ট্রান্সপ্লান্টের ক্ষেত্রে। তবে অ্যান্টিবডিটা মোর কমন, যেটা বেশি হয়, তবে যেটা অ্যান্টিবডিটা বেশি কমন, কিন্তু সেল মেডিয়েটটা যদি হয় সেটা ট্রিটমেন্ট করাটা ইজি দেন অ্যান্টিবডি মেডিয়েটেড রিজেকশন। আর যেটা করতে হবে এটার জন্য যে যদি কারো হিমোগ্লোবিন কম থাকে তাহলে ব্লাড ট্রান্সফিউশনটাকে অ্যাভয়েড করতে হবে, এবং এই ক্ষেত্রে আমরা এরিথ্রোপয়েটিন অথবা আয়রন বা অল্টারনেটিভ কোনো মেথড দিয়ে ব্লাডটা হিমোগ্লোবিনটা মেনটেন করার চেষ্টা করব, তবে আননেসেসারি ব্লাড ট্রান্সফিউশনটা অ্যাভয়েড করাটাই এই ক্ষেত্রে বেস্ট। ওকে, I have a question for ma'am also, and there is let me, ma'am, can you hear me?
Yeah.
Is there any special test for second transplantation, who are underwent for second transplantation, to reject this kind of rejection? To who can actually there is a question from audience. She want to know that is there any test that can help her to prevent the antibody mediated rejection in case of second transplantation?
So the main test, so antibody mediated rejection, as already mentioned in this whole program, is that it can occur either late or early. Early can occur as early as on table. That is, you put in the kidney and the kidney rejects in front of you. It can occur in a few days and a few weeks or months or years. Now, considering this, one of the only test where we can detect the risk of on table rejection is a cross match. So a CDC and a flow cross match being negative puts you at lower risk. I wouldn't say zero risk, a lower risk of on table antibody mediated rejection. The second part of this is the antibodies itself. So when we do something called as class 1 and class 2 antibodies, we see whether there are antibodies against the donor. So what we do is we have your antibody profile and the patient's HLA typing. So then we see whether you have any antibodies against the donor itself. This is called as a virtual cross match. So you have an actual CDC and a flow cross match, which is a physical cross match, and then you have this, which is a virtual cross match, where we see whether you have antibodies. Other than this, there are other antibodies also. So anti-HLA antibodies are not the only antibodies which can cause rejection. Newer and newer research shows that there are other antibodies like minor HLA antigens, etc., which can cause rejection. So if you are planning for a second transplant and you still don't have a donor, the first thing you can do is do a baseline PRA. A PRA of more than 50% generally indicates, or rather more than 20% generally indicates, that you are at a higher risk of antibody mediated rejection. Then, but the PRA is not all of it. So when you actually get a donor, you should do an baseline cross matches at various levels with this donor to see what is your risk of rejection. The best donor will be the one where your CDC is negative, flow cross match is negative, and you don't have any anti-HLA antibodies against your donor. This is your best scenario.
Okay. So ম্যাডাম যেটা বললেন সেটা হলো যে রিস্ক অফ রিজেকশন সবসময়ই থাকে। তো বেস্ট হলো যে আমরা তিনটা পরীক্ষা করে নিব আগে, সেটা হলো সিডিসি ক্রস ম্যাচ, ফ্লো সাইটোমেট্রিক ক্রস ম্যাচ। যদি এই দুটা নেগেটিভ থাকে সেক্ষেত্রে চান্স অফ যে গ্রাফটা কিডনির বেশি দিন সার্ভাইভ করার চান্সটা বেশি। আর আর এই ক্ষেত্রে অ্যান্টি-এইচএলএ অ্যান্টিবডিও দেখা যেতে পারে। আর আদারওয়াইজ এছাড়াও এইটা দিয়ে আমরা আসলে মেজর অ্যান্টিবডি গুলোকে দেখি, দেয়ার ইজ সাম মাইনর অ্যান্টিবডি যারা রিজেকশন করতে পারে। সো এটা কখনোই একদম ফুল বলা যাবে না যে রিজেকশন হবেই না, বাট যদি কারো ফ্লো সাইটোমেট্রি সিডিসি নেগেটিভ থাকে তাহলে গ্রাফট সার্ভাইভালটা কম্পেয়ার যে ভালো ভালো আমরা আশা করতে পারি। ওকে ম্যাম।
Sanjeev, there is one question I think we can take. Mr. Mohammed Hassan has asked, his disease is IgA nephropathy. What is the treatment if it comes back in the transplant, and how effective is it? I will just add to that and ask, when can you generally get back IgA nephropathy?
Okay, there are multiple questions being asked there. So I think we've spoken about what steps that they can take to prevent antibody-mediated rejection. IgA nephropathy is one of those diseases that can come back in the transplant kidney. So the thing is, even if it shows up in the biopsy, many times the treatment for IgA is the steroid and tacrolimus and MMF that you're already taking for the immunosuppression. So you're already on treatment for it. So because of that, what normally happens is that even if you develop IgA in the graft, it does not cause graft rejection. The rates for whether it comes back in the transplant kidney, depending on which series of studies you're looking at, is somewhere between 30 to 50%. That it may show up on the biopsy, but usually does not cause graft dysfunction because you're already on treatment for it with the medicines that we would normally use to treat IgA nephropathy. And usually it is seen 6 months to 1 year after that the IgA shows up on the graft. Kumar, if you want, I think that should be fine. There was a specific question asked in English, so he should be able to get that answer, Rajiv.
Yeah. So I think the last question is, what is the side effects of MMF? I think one of the commonest side effect is diarrhea. You can have GI side effects, that is gastrointestinal side effects, not able to eat. Diarrhea is quite common. You can have a low blood count. These are the common side effects of MMF. Obviously, that is a high dose of MMF. Low dose MMF obviously will cause rejection because you're not immunosuppressed enough. And low magnesium levels can cause cramps, low potassium, etc. So you should supplement yourself with magnesium, both in the diet as and orally if required. So I think we've taken all the questions in. Mr. Nuzuraman Sheikh has asked the same question. I think what precautions to take to prevent extra antibodies.
I think that question has been answered more than a few times in this chat. If there are no more questions, you want to hand it back to.
Yeah, Mr. Rafiq. Mr. Dr. Umar.
Epitope. Rajiv, there's just a new question on epitope matching for DRDQ. I don't know. We are not doing it. You want to take that, Rajiva? Talk about epitopes?
Yeah. So we are not doing epitope matching for DR and DQ, but especially when you're going for a second transplant, it may be a good idea to do it. The problem with epitope matching is that, especially in a country like ours, is that we may not get a donor very easily. There are programs in the West, like the US, where they reject patients, even living donors, based on an epitope mismatch. Unfortunately, I don't think we are at a place, or we don't have the luxury of saying no to somebody just based on an epitope mismatch. That being said, now if somebody the epitope mismatch comes into play only when you don't have any anti-HLA antibodies. If you already have anti-HLA antibodies, there is no need to further see epitope mismatch. You already have a risk of rejection. So only when there is a no antibodies, your cross matches are negative, you are doing a more sensitive testing to see if epitope matching is there or not. So that's my take on epitope matching.
I don't think anybody in India is doing it. It's still largely being done in the West only.
I think there is one program in the West, in the US, which does it as a study currently, where they run a pet kidney transplant program based on epitope mismatches. I think how can reduced or stop protein leakage after transplant, Sanjeev?
Okay, so usually protein leakage most commonly in a kidney is because of diabetes or hypertension. So those are the first two things that you would control. Control your diabetes, make sure it's your HbA1c, FBS, PPPs are normal, and also your BP. You can have protein leakage because your original disease has come back again. If that is the case, you will probably need a biopsy to confirm that it is a recurrence of your original disease, and then you'll have to take treatment for that. So the way to look at protein in the urine is to figure out why it is happening, identify the cause, and treat it. But to prevent it, the best way to do that is to ensure that your diabetes and hypertension are under control. There is also the kind of diet you take. If you already have some protein leak, don't load up too much on dietary protein. So your non-veg food, especially red meats, should be less. Uh, you'll have to get a proper dietary consult and talk to your nephrologist to see how much protein you can take.
Dr. Umar is not there. I will just take that next question. See, so we have to examine you, Mr. Hassan, but essentially such sort of pain post chicken pox or rather zoster, is very, very common, because zoster affects the nerves, and the pain can last for a while, for more than 3 to 4 months. You can have quite a bit of pain. Please talk to your consulting doctor to see whether any other pain medications which is safe for the kidney can be introduced. Dr. Omar, any other audience questions? If not, then we can give it back to you and Dr. Rafi, Mr. Rafi.
Ma'am, there was my little bit technical issues there.
Yeah.
There is, wait, let me check, ma'am.
Ma'am, am I audible?
Yeah, sure.
Yeah.
Hi, Rafi.
Ma'am, we have some question from the audience, and we take some question from the previously. And some question was that, is it safe to continue microfinillate without doing MPA level?
Sorry, I couldn't hear you. I don't know whether
I think the
Sanjay
question was, I think the question was whether it is safe to take mycophenolate without a MPA level.
Yes, sir.
Yeah. So in almost all centers in India, mycophenolate is given without the MPA levels being monitored. It is, I think, in South India, it is being done only in CMC Vellore. It's very expensive to do and not an easy test to do the MPA levels. By and large, the mycophenolate is a safe drug that you can take without monitoring the levels. And we decide how much to take and whether you need to decrease based on clinical response. So by and large, it is like that. It's usually a luxury to have that test to do.
Okay, sir. So we have another question from an audience. They said someone using ketoconazole or deltiazem to increase tacrolimus level. Someone saying, is it only increase the plasma tacrolimus level, or is it influences the tissue? Is it reached to the tissue after taking ketoconazole or deltiazem? And how much safe it is to take ketoconazole cardigan to increase tacrolimus level?
So I think overall, when you look at tacrolimus levels, it differs from patient to patient. Like for example, in our center, we do something called as a tacrolimus metabolizer level. If they are very poor metabolizers, you don't need extra drugs to shoot up the level, because the drug is going to remain in the plasma for a longer time. So if they are very fast metabolizers, that is, they are metabolizers where the drug gets metabolized very fast, obviously it does not stay in the blood long enough to act. So in these scenarios, instead of just hiking up the tacrolimus level further and further, we have seen in certain country people, we see that the tacrolimus levels can be very low, despite like they may be taking 6 mg twice a day, but the level never comes up. So in such situations, we add either diltiazem or ketoconazole, because it interferes with the metabolism of tacrolimus. Okay, so
Yeah.
that's when.
One
So
question
pretty much,
from Nurjan.
if the level
Okay,
is good
okay,
in the blood, it will act on the tissue.
okay, sir. Okay, ma'am. Another question from Nurjaman Sheikh. His mother's age is 65. He want to donate, and his ZFR from the right kidney is 42 and left kidney is 39. Is it possible for her to do for a kidney donation? And he has a cousin, he is 29. His GFR of right kidney is 77 and left kidney is 79. Which will be better? And this question was from Nurul Jaman Sheikh.
Yeah, overall little.
Ma'am, will I repeat?
No,
I
it's
mean,
fine.
saw
I
it
see.
on the
Look,
chat box.
the younger donor is obviously overall a better donor. Uh, the cousin, sometimes you have to look at the relation and how you can establish relationship in the Indian setting. But otherwise, a younger, healthier donor is better than a 65-year-old lady with a what we call a marginal kidney. There is another question in the chat box that I think we should address. If protein
Ma'am,
leakage
one
occurs in a donor kidney after
the
20
question
years,
from and is question from Arjun Rafia. He got a baby most probably 2022 or 23, and after pregnant after giving birth a child, after 6 months he got pregnant again. He delivered a healthy girl, baby girl, and she is fine. And after 6 months, he uh, unfortunately, he got pregnant again. And he is continue, and doctor suggest him, her nephrologist suggest him to continue with the baby, carry on the baby, and what should be her guideline to continue the rest of the life during this pregnancy with a second baby.
Sorry, how many years post transplant is she?
Most probably he went for a transplant in 2019, and
Yeah, so
2023 he got a baby girl, and she was
yeah,
fine and healthy. And everybody,
I got that. Basically, pregnancy post transplantation is possible. Generally, we give at least 1 or 2 years post transplant with a good graft function without any rejections, no high blood pressure, no protein leak in the urine. So, if all these things are not there, then she can continue her second pregnancy. That being said, she has to be monitored closely for high blood pressure. She has to be monitored closely for protein leak and creatinine. And also, the anti-rejection medicines may have to be slightly altered in terms of MMF may have to be stopped. She will be having to take azathioprine. Tacrolimus will be continued, and things like that. She may need aspirin because she is at a higher risk of high blood pressure, which is called as preeclampsia.
most probably she's taking aspirin in injection form.
Well, rejection can always occur. We have seen it during pregnancy because levels can differ and we are changing the drugs. So we have to just closely monitor for this.
Ma'am,
I
one
think
question
after
from
this, multiple pregnancies may cause more problems. Probably it would be wise after this to be more careful not to have another pregnancy after this.
ma'am. Multiple pregnancy. The problematic thing is he got pregnant after the 6 months between the delivery and the period.
I know, but that's okay. Now that they are continuing, and if everything is all right, it's okay to go ahead.
Okay, ma'am. Thank you. Another question from another audience. And is it really necessary to go with denosumab 60 mg regularly once after 6 months in a regular basis for
Can you
preventing
please answer
osteoporosis?
the denosumab question?
I didn't hear it. What is the question?
Do you need to
Uh,
take denosumab once a month post transplant for
once,
bone?
once a month, maybe, once after 6 months.
Yeah, once in 6 months post transplant.
So denosumab is, oh, sorry. You would use denosumab based on, see, we would have to check this patient's bone density. Unless it is indicated, we wouldn't use it. It's not a cheap drug also. So unless it's indicated, we wouldn't use it on a regular basis. What we normally do is after 1 year on steroids, we can do a DEXA scan to look at bone density, and then, if required, only then prescribe it. Otherwise, we don't prescribe it.
Okay, Dr. Umar Farooqi here. Most probably will continue the rest. Sir, please.
There's one question in the chat by Sohani Ferdowsi about a donor having proteinuria after 20 years of donation. I
Yeah,
thought this is
that should be
important. We
addressed.
could just address. So the question is, protein leakage occurs in a donor kidney after 20 years of donation. She is non-diabetic but hypertensive. What to do now, Rajiva?
So if she is, so first of all, a patient with a single kidney, that is a donor who obviously has a single kidney. So if the hypertension is there, the hypertension has to first be controlled because a very high blood pressure may cause protein leakage. So the high blood pressure should be controlled. Second, if the person is overweight, then that also we have to see because being a single kidney, they can have problems like secondary FSGS, and obesity itself is a known risk factor for extra protein leakage from a single kidney. And if the BP is well controlled and the obesity is not an issue, uh, then we have to evaluate further, do further tests like creatinine, etc., and see if she needs or he needs kidney biopsy, though it is a bit risky because there is a single kidney. But basic risk factors like weight, high blood pressure, etc. has to, and also drugs. If they're taking any native medications, any painkillers, those things have to be stopped. Especially if there's a protein leakage, has to be taken seriously because it's a solitary kidney currently.
Ma'am, last question from an audience, and then after that we can end the show. That is a person asking that there is two donor. One is the patient's mother, which is 65 years old.
Yes,
That we took, Omar. That
we have
finished.
answered.
My answer, ma'am, I was not in connection there.
Yeah.
This is Dr. Mr. Nuruddin Sheikh's question. We have answered.
Okay.
I think from my side, I really wish to thank Mr. Rafiq for this opportunity to interact with such lovely audience who were very interactive, asked very relevant questions. And it's not an easy topic to discuss even for nephrologists. And I thank you for the opportunity given to us to interact with you. Sanjeev?
Yeah, I agree. Thank you so much, Ms. Rafiq, for organizing this. Thank you to our audience for sitting. I know it's late night on a Saturday, and the questions were also very useful. And I think everybody who's listening would have learned something from it. And I hope we were able to solve or at least address some of your doubts.
So before ending, I have a question for all. And how, ma'am, please. And this is the question is how they will take myfortic or Cellset after food or without food. What will be the season, and how they will take tacrolimus? Will it empty stomach or after eating food? And this is the most common question from all of us.
Rajiv, are you there?
Yeah,
Like,
Sanjeev, you want to take that last question?
All right, fine.
So,
So tacrolimus you take at a fixed time every day. Generally, we say 8 o'clock in the morning and 8 o'clock in the night, so that the drug levels of the of tacrolimus don't vary. Okay. Mycophenolate is usually taken after food.
Okay, sir. Thanks everyone. And I would like to thank everyone, all of you. And this is a private group. We have all about 500 more transplant patients. They are all hearing it or hearing after live. And I would like to thank everyone for being here. Hope you will be available after 1 or 2 months when we will be required. And this is a platform of a non-profitable organization. There are more doctors. They are come and talk with patient. And most probably we try to support patient, try to support the sufferers. And our motto or goal is to educate the transplant patient or kidney-related patient. And now I would like to thank everyone for being here. Good evening. Thank you.
Thank you so much.
Thank you so much. Thank you so much.